Snodgrass is Chief Executive Officer of Sun Behavioral in Columbus. Sun is a private equity-backed and for-profit 144-bed psychiatric hospital that opened in May of 2017. I met Scott when he and his wife Georgia and their tribe of children moved here in 2018. And yes, we found them a lovely home. Scott has a Bachelor of Science in Sociology and a Master of Arts in Counseling. Scott has spent nearly all of his career in the behavioral health industry, serving in many capacities, which I feel like really equipped him for his current role as Chief Executive Officer at Sun. Scott is going to share some of his insightful information about his industry, but I wanted to give you some insights about Scott Snodgrass himself. Not only is Scott a wonderful husband and father, he's a pro at hospital operations, strategic management and growth, strategic relationship building, process management, regulatory oversight, market research, change management. Well, you get the idea. He's very qualified at what he does. But the more I get to know Scott, the more I realize his greatest strengths are that he's smart, thoughtful, and he really cares. He cares about his patients, their families, and his staff. I'm so thankful to call him and his wife a friend, and that this wonderful human being is running a behavioral health organization. We need more people like him to navigate the ever-growing challenges of behavioral and mental health and addiction. Please welcome Scott Snodgrass.
Good afternoon. That was a really nice introduction. I appreciate that, Joanne. Okay, so just to level set, by show of hands, who in here knows someone who is currently struggling with addiction or is in recovery from addiction? Who in here knows someone who is currently struggling with mental illness? Yeah. So it's a thing, right? It's a thing. So just kind of want to set the stage. Just want to give you a peek inside the walls of a psychiatric hospital. And yes, it is a crazy business, no doubt. So you may recognize this. Some of you maybe. I'm not a native of Columbus, but this is the former Clarion Hotel in the area called the Continent, okay? I'm told the Continent was the place to be in the 80s. Some of you are nodding your head. So only like 1 in 3 of my patients say they partied at the hotel, and only 1 in 5 in staff, right? So we took a dilapidated hotel, and we'd like to think that we turned it into an environment for recovery. So it's 144 beds, inpatient beds. I've got adults, I have geriatrics, I've got a unit now just for adolescents. We opened that in August. And so each unit is kind of set up in like 18 beds. Each floor is 36 beds for a total of 144. And then we have some outpatient services as well. Behavioral health. And I know many of you are business owners, work in business. It is a complex environment, particularly psychiatric hospital. So that bucket on my far right over here, the systemic societal issues, imagine trauma, poverty, mental health, behavior health, transgender, domestic violence, substance use, all of that chicken coming home to roost in one environment, also known as my hospital, right? So all systemic societal issues end up there. So we never have a boring day at Sun Behavioral, but a very complex thing, because a lot of variables and things we can't control, we don't influence, right? The next bucket that makes complex is the payers. Who's gonna pay for behavioral health, right? Is it Medicaid? Is it grant funding? Is it commercial insurance? In many ways, inpatient psychiatric services don't even meet the scientific method right? Because it's not observable, it's not repeatable, and payers don't necessarily want to pay for the stay, right? So we end up maybe getting like a 3 or 4 day stay, and we battle and we fight the payers to get day 4, 5, and 6. So it's very complex. It's not like if you have a heart attack and you go to a med-surg hospital, basically you're going to be in ICU for 4 days, you're going to be in post-acute rehab for X number of days, and 80% of the patients fall within that. That's not the case with behavioral health. Again, too many systemic societal issues, things that we do not control that impact that payer bucket. Regulatory, CMS, a body called the Joint Commission, they have these zero suicide initiatives. So imagine, when you're in an environment, everything has to be really kind of dummied down. It has to be a very safe environment. And the cost to do business from a regulatory perspective is almost unaffordable. And that's why you're starting to see a trend across the country that this inpatient psych providers, you can't afford to do business. It really is regulatory gone wild, and it makes it a complex business. This next bucket may be a head scratcher, but it's a thing here in Columbus especially. So it's very competitive, and many of you may find that surprising. So in the last 2 years, in a 16-county region in central Ohio, we've added 434 inpatient psych beds. So now we have 2 Fortune 500 companies that are in the market, Acadia. We have 2 Springstone hospitals. There's us. There's another one in River Vista. And then there's all the med-surg health system beds, right? So it's very, very competitive. In fact, when we do an analysis in the market, we're about 122 too many adult beds in the market, which is essentially a whole hospital. So what that's created is we're cannibalizing each other for staff, and we're cannibalizing each other for volume. And staff, especially, if you're a behavioral health nurse, you can write your ticket. If you're a psychiatrist, you can write your ticket. The 2 hardest physicians to find in healthcare today is a neurologist and a psychiatrist, right? So the days of the psychiatrist being a flunky out of med school, they're certainly having the last laugh because they can call their shots. But very, very, very competitive. And so what wins the day there is culture, innovation, a lot of things that I know many of you are dealing with, right? And then the last bucket that makes it difficult, and I alluded to it in the payer bucket, is discharging patients. Very complex. We see a lot more geriatric senior patients that have Alzheimer's dementia. Hard to discharge those folks home and do it in an ethical way, right? Even when they don't have days. I still have customers taking beds because we cannot ethically discharge them when that bed is not being paid for, right? I have adolescents now. I end up in my lobby, I have parents who are deciding who's going to be, going through a divorce, who can see the kid, who can't see the kid, who can make the decisions about the kid, who can't make the decisions, right? Some of the kids don't even have parents. The state of Ohio is their parent, so they're making decisions. You can't get a hold of them, right? Insurance is only approved 6 days. I can't discharge them to the streets, right? So very complex stuff. And you see it a lot too with, substance use or trauma. Discharging patients, even when those days and beds are not being paid for themselves, is a complex ethical, moral issue that we have to decide and make decisions every day about people's lives. It's a weighty thing to have to make these decisions. Like, is this person going to harm themselves? Are they going to hurt somebody in the community, right? And in the meantime, I've got the stresses of the financial stats too. My EBITDA stat has to look good, right? No margin, no mission. But again, and this is just, a sampling of the complexity of the business, but I wanted to give you a peek and a preview into what it looks like to run a psychiatric hospital. A lot of things I could talk about today. Something I think is interesting, opioids. Gets a lot of airtime. Many of you may know somebody struggling with, pain management or pain med addiction, heroin, now something called fentanyl. And it's really this perfect storm. So back in the day, if you were a heroin addict, it was black tar. So that's black tar heroin, right? So to use black tar heroin, you had to get a coffee grinder, cut it up in a grinder, put some sleeping pills in there, right, as an additive, and then you'd have to cook it down, melt it, put it in a needle, and inject it, right? There's a lot of steps there. So you got to be way committed if you're going to be a black tar heroin user. This changed the game. Pain pills. Hear about it all over the place, right? So the latest stat that I heard is that we in America consume 80% of the world's pain pills, and we only represent 7% of the world's population. Unbelievable, right? But this, in my hospital, if you come to my hospital, this is where everybody gets started. Nobody talks about marijuana as the gateway drug in my hospital, right? So marijuana is not a thing in my hospital because this is a thing, right? So many of them start here. And as you begin to build a habit, you can no longer go to your primary care doc. You've shopped all your doctor's shop. You're running out of resources. You will hit the street. And a street for, if you hit the street for about a pill of Oxy, it's about $30, right? So your tolerance is going up, your expenses are going up, right? And you're running out of resources from an economic standpoint, right? So then you can go from here to here. And you will, and they do. And, a button of heroin, a button is just a capsule. It's about $5 on the streets. And it's about 80 to 90% pure. So now I don't need to take 10 oxys. I can just do one, $5 button of heroin and snort it. I don't even have to inject it. I don't have to go straight to the needle like you had to do a black tar, right? So there's a transition. So once this captures you, hijacks the brain, then you move. You will eventually, they all go to this. So again, it's a matter of economics at play. It's a matter of tolerance at play. But once you eventually end up injecting, it's about 7 to 10 times stronger than snorting. So again, you need less to keep the machine going. But by the time if you're at this point, the wheels are really starting to come off. The game has changed. It's not even heroin now. It's fentanyl. And I don't know if you can see this. But they're comparing how much heroin and fentanyl and carfentanil you would need. So you can see how many, looks like little salt specks. Not a lot of fentanyl compared to the heroin. So now the addicts who roll into the hospital, what they really want is the combination of heroin and fentanyl. Because fentanyl gives you a real intense high in the beginning, right? But the heroin kind of brings it, lets it ride a little bit longer, okay? So now the patients are wanting the fentanyl, right? So the synthetic stuff that's coming from China. I had a patient that I talked to a few weeks ago, really smart, and that's the sad thing about this. Smart, talented, gifted people who could be contributors, not just consumers, are getting hijacked and caught up in this. So this guy, he had overdosed in the morning, and it took 6 Narcan. If you know what Narcan is, it's the drug that they use to bring you back from the brink of death. And so with heroin, you might get away with 1 or 2 Narcan. With fentanyl, now it's 5 and 6, okay? So the guy was brought back from the cusp of being, at his death. And he's resuscitated. And here's the thing, 90% of those who are resuscitated by EMS refuse medical treatment because you've ruined their high. So you want to be on the cusp of death. That's where they want to be. So this guy, this happened in the morning. In the afternoon, he went back to the same dealer who sold him this combination of fentanyl and OD'd again and took another 6 Narcan to bring him back, right? But that's my point of that is to demonstrate just how wicked and twisted and sick this thing is. Who's driving the bus? I'm not sure, but it's certainly, I don't believe them. They wouldn't do this on purpose if they had all their faculties. But this is what we're up against. And there's a whole, set of economics around this. But scary stuff, scary. We have 4 kids, Joanne mentioned, in our tribe. It's this scares you, right? This keeps you up at night. Now, this is where it gets interesting. So we're talking about what contributed to the opioid epidemic. This question, the single question in healthcare, is called something called a Press Ganey. Okay, Press Ganey is a patient satisfaction survey used in hospitals. Okay, this used to be the question: how often did hospital staff do everything to help you manage the pain? Well, what is great at managing pain? Opioids manage pain well. They do a great job managing pain, right? Friends, business owners, be careful what you measure. Be careful what you incentivize. You may just get it. There's a whole human capital consequence effect from this one question. Hospital staff, system staff are incentivized by their quality metrics, okay? So this is a thing. This is no longer on the Press Ganey, thankfully, but this is also a contributor to the epidemic that we're experiencing today. The war on drugs, $1 trillion since the 70s. You see the breakdown, $450 billion to lock people up, another $20 to fight the drug gangs, $49 billion for law enforcement, $215 billion for an overburdened justice system, $33 billion for Just Say No, right? $33 billion for Just Say No. And then $121 billion to arrest more than 37 million of nonviolent drug offenders. It's a lot of resources being thrown at this. Thomas Insel says the economic cost of mental illness would be more than cancer, diabetes, respiratory ailments put together. And it's true. So I used to work in a healthcare system, a 4-state hospital system called SSM Health in St. Louis, and everything in the healthcare system is a service line. Behavioral health service line was in every service line. So there you could find behavioral health folks in cardiology, pulmonology, oncology. No other service line can say that. It's everywhere. And it's in your businesses too. It's in your families, in your community. Just the global burden of disease. You can see that neuropsychiatric disorders, including substance abuse, gets the biggest piece of the pie. And the other thing that is not identified on this, the neuropsychiatric disorders are all the other ones too. Because they're all a contributing factor to your physical health, not just your mental health. And some of you may be dealing with this today. Just the lost workplace productivity, right? Like, what do we do about this in your workforce? I have it in my workforce. There's something called a mental health day. My staff are taking it. You may have a similar experience. That wasn't a thing a decade ago, right? Mental health day. Depression and anxiety cost the global economy an estimated $1 trillion each year. Mental health and substance abuse cost U.S. businesses an estimated $225 billion annually. And mental health costs America 193 lost earnings per year. So I'm sure many of you in your HR departments are wrestling with how do we keep our people healthy, because the people are the product, right? Certainly in my business, we don't produce widgets. I'm only as good as my people. And if my people are suffering and they're not in a good place, guess what? The care that we provide suffers. The outcomes that we're pursuing are compromised. So where do we go from here, and what can you do? I think this is the perfect audience too, just with the mission and vision of the Rotary. But we've got to make it okay to have the conversation. The shame and the stigma is the super glue to keeping this thing going. And each of us have this in our families. Many of you may struggle with these same concepts yourself. But nothing good is going to happen unless we give permission to allow our employees, our loved ones, our community to raise their hand and say, I'm struggling with whatever. We have to make it okay. Remove the judgment. And each of us can do that. Your leadership, whether it's in your organization, whether it's in your family, whether it's in your community, You have to think about if it is in your business, what type of culture are you creating? Is it a command and control, carrot and stick, right? That theory X, theory Y, Dr. Deming philosophy. Are you creating a type of a culture where people feel safe, they feel healthy, they can be healthy, right? Do you care about your people? And then lastly, the answers are within the community. They really are. There's no nonprofit, no government organization, no healthcare system who can come to these communities where this exists and want the answer, want it more than they want it themselves. The communities have got to want this. The families have got to want this. The problem is way too complex for nonprofits, government, healthcare to solve. It's way too, law enforcement included, right? Way too complex. So I believe that the answers are in the community, right? And many of the things that you guys do, right? In the community as a function or result of Rotary, your fellowship between the businesses and the communities and the partnerships that you all, that you have, the programming you have, all have the capability and the opportunity to impact this important conversation. I just want to leave you with this. So prioritizing mental health and emotional well-being of your employees will increase profit, improve lives, and transfer culture. I believe that. I really do. Again, the healthier your people are, the healthier your culture is going to be. The saying that culture eats strategy for lunch, I totally agree with that too. You can have the best laid strategy in the world, but if you don't have the people to operationalize that strategy, it'll never get off the ground. So I want to give you that as a lasting thought to think about. When you think about how you will work with your communities, your businesses, your families when it comes to this very, very important conversation. I'd like to open it up for some questions if you have any questions.
What are you able to do for your employees? Because as you're saying, this is important. They're taking care of the patients. What are you able to do to make it a priority for your own employees to be mentally and emotionally well?
Yeah, so to keep my employees healthy and mentally well, don't have all the answers to that. But one of the things that I'm sold out for and committed to is creating a culture that makes it that they know that I'm with them. I have a presence with them. I also create a culture where safety is a priority, because you can imagine inside my walls, it's not always the safest place to work. There are people get hurt, right? So safety, my presence, and then we have services like EAP, right? We're talking always about, the toxicity and the sometimes gossipy culture that can happen inside walls. And again, if those things are not addressed, they will impact quality care. They will impact your people's performance. It will impact their personal well-being. And then we also have like values committees and different things, a lot of mechanisms for receiving feedback from staff. And I personally am up on the units every morning interacting with patients and staff myself. So I'm really accessible. So not that we have it figured out, but trying to create an environment where if you need to tap out because you're feeling a little stressed, why don't you come over here and I'll jump in for you.
You had mentioned earlier the transitional dilemmas you have when discharging patients. What kind of, have you created any sort of relationships with other entities to help for the transition when someone's being discharged?
Yeah, so the question is, are we creating like collaborative relationships with those organizations we discharge to? And we do. A lot of our patients, so my payer mix is about 50% Medicaid, and a lot of the Medicaid patients are already linked to what we call a community mental health center. So I guess it was in the fall we had a community mental health center, Columbus area, close. Anybody remember that? 50-year organization, served a lot of this population. So the challenge for us in this community is now we're left with 2 mental health centers, southeast and north central, and they're being overrun. And the other contributing factor to this is there's not enough psychiatrists, and psych MPs to manage all the meds in the community. So a lot of these folks end up going to their primary care docs, and primary care docs are scared to death of this stuff. They don't know what to do with it. So again, we end up in these complex societal issues that I don't necessarily have the answer for. We do partner with our partners as closely as we can. But then there's also folks who just don't want help too. That's also another piece of this. And it's kind of elephant in the room at times, but yeah, some folks don't want help, and we oftentimes may want it more than they want it for themselves. And if you've ever been in that position with a loved one, or especially somebody who's in active addiction, that never works out well. So many hands, I don't know what to choose. We're right here.
Yeah. What percentage of the people are affected by mental health in this country, and do you have comparative data for other countries?
You know, that's a great question. I wish I had the answer for that, because when I cite some of these studies, I don't know how they are able even to capture the data. Because what I see, it seems so underreported to me, but I also lived in a very warped world. So I don't know, but my instincts tell me that we're not as good as a lot of the other countries, because we are we are built on productivity. We have a culture of instant gratification, right? And some of the narcotics that I talk about, especially opioids, instant gratification. Another ones is benzodiazepines. Work really well. Great question. I don't have the data to that, but my instincts tell me that we're not maybe as good as some of the other countries. Mix it up over here.
Yes, my question has to do with Narcan. It's in two parts. First, is it a ubiquitous cure for various causes of overdosing? And secondly, how does it work so fast?
So I'm not a Narcan expert, but essentially it binds the heroin, the opioid to it, so then it can get off the brain receptors, and then the brain can wake back up from this place of death. And it will wear off. So depending on what the person has in their system, they can actually, once the Narcan wears off, those binding receptors wears off, they can actually overdose again, and without ingesting any new drugs. It's certainly not a cure or a strategy. It's a drug that's used to resuscitate life. And it's incredibly expensive now. Just ask your local fire department, especially now that they're having to use 5 or 6 at a time, and it's $30 to $40 a pop. And it's becoming increasingly harder to get. Let's go in the back right there.
Beyond Narcan, for the instance of their crises, to wean a patient off of these debilitating fentanyl and opioid addictions, I understand there's a drug that only 6% of family doctors are even licensed to prescribe. But my question there is that the only way to get someone off, is through that aggressive drug treatment to unwind that addiction?
So now when you start talking about addiction recovery, you can get into a heated debate because a lot of folks who have come up through AA and they're in their own recovery, they are very staunch on no meds, right? You got to get sober the way I got sober, right? And then when it comes to what we call medication-assisted treatment, which is the gentleman is referring to, there's something called Suboxone. So Suboxone is a drug that's used for patients who are opioid addicts that decreases the cravings, so you can get well enough, long enough, just to maybe get some good things happening in your life. But that's very controversial too. Some physicians don't want to touch it, to your point about 6% only having the license and the waiver. Some only maybe want to do it for 10 days, like a 10-day protocol. And then there are some who are of the opinion that we should treat it like diabetes and they should be on it for life. For me personally, however you get to recovery, I don't necessarily care, if it's celebrate recovery, if it's cold turkey, if it's medication-assisted treatment, AA, NA, it does not matter. But people do swear by the meds for sure, and then some people will say it's just a replacement drug. Right here.
About 5-6 years ago, my daughter had foot surgery, and I'm sure it was very painful, but the doctor prescribed 4 oxycodone a day for 30 days. He gave her 120 pills, and my wife gave her 1 and then Tylenol. But is there some education? Have things changed a little bit since then? Are doctors becoming more aware?
How long ago was that?
Probably 5 years ago.
Yeah, there's been a big movement to, especially at the emergency room level, where you had a lot of folks coming in, complaining of pain. They were leaving with a script for pain pills. There's been a lot of education around the use of opioids, especially with primary care. You still see it with the pain management docs, right? So like people with back pain, and there's still quite a few. There's I wouldn't say an overprescription, but there's definitely a path there for opioid abuse. But like the general surgeons, I'd like to think that yes, there's been some education there. I know in other states, even like hospital systems are getting together and having the same opioid prescribing protocols, because you can imagine even if one healthcare system, say Ohio Health, figured it out, but Mount Carmel didn't, then all those patients would just shift over there. So there has been some collaborative work amongst health systems to recognize that there's a consequence to these drugs, right? And 120 is excessive. Yes, ma'am.
I just have 2 thoughts. The first is I see a lot of people that come to me and ask what they can do about their child who gets hooked on something. And some of them have had to give up rights to their child to get treatment because they didn't go through the court system. Number one, is that changing? And the other thing is, the thing I see as a health professional is that people who do need pain medications are not getting them now because the doctors are being watched so closely for that, that I had a friend whose daughter went into labor, and in her epidural they refused to give her anything for pain because of all of these drug rules, and I think that's ridiculous.
There is, you're hearing more of that now, where the pendulum is actually swinging to the other side, and those folks who actually need the meds, they're not abusing the meds, their intentions are pure. They can't get them because the docs are so scared when it comes to their license, right? First part of your question, I've only been in Ohio about 1.5 years, so I don't know all the rules and how custody and all that works. I'm learning a lot now that we have adolescents. But maybe you're talking about like drug court. They had to give up some sort of rights for the kids to go to drug court program, which is like a jail alternative, which also has like a treatment component. It keeps them out of prison. So the drug courts as a whole have really, really, really good outcomes. I know I see it with some of the kids that, yes, some parents have to make really difficult decisions that give their kids up to like children's division because they don't have the resources to put their kids in the type of long-term programming that sometimes the kids need. And that's tough. Terminate rights for care. Because Medicaid, and again, going back to the payer, they don't pay for all the interventions that may be required, and then even if they do pay, it's not always enough. Yes, ma'am.
What do you see any trends towards alternative treatments for these kinds of things? More accepted things like meditation, acupuncture, those kinds of things. Why is our healthcare system and our insurance system fighting those kinds of things when they've got these other devils that are, much worse than the problem?
Yeah, that's a great question. So we have, in our hospital, we have yoga. So our patients have yoga, and staff has the capability to do yoga on Mondays and Fridays too, as another kind of intervention to Joanne's question for wellness. We teach a lot of meditation. We do a lot of that. We have pet therapy, we have music therapy, we have art therapy. So we have a gym, so you just get up and move, get off the unit, kind of change up the scenery. So absolutely, do those modalities have a role? For sure. You can't bill insurance for them Because so that's the issue. You know, we have this system where you have to use something called a CPT code to be able to bill the insurance in order to get paid for the services. So some of those other modalities require resources that are not compensated. And so you have to make a commitment as an organization to do some of those things without a stream of revenue.
Yeah, and I've done a lot of work in the long-term care industry, and there's no reimbursement for activities and quality of life things that would, if you give them a pill, if you give them a shot or whatever, there's reimbursement for that, but there's no reimbursement for anything that makes quality of life better.
Yeah, I think that's the debate of Western culture medicine versus maybe some of the Eastern culture, and those are interesting conversations, for sure. Yes, sir.
Of the growing army of panhandlers in Columbus, what would be your estimate of the percentage of those who fall into the category of what you've been talking about?
That's a tough question. So with the growing number of panhandlers in our community, what percentage of the panhandlers are the folks that I'm talking about? I think certainly there's a percentage of those folks who are presenting in our hospitals that struggle with addiction, and quite frankly, quite a few mental health too. But I'll say unequivocally, like what I see is it doesn't discriminate though. Like I see this high functioning white collar to blue collar to no collar at all, right? And panhandling, and kids, and that is the trend too though that I'm seeing. Kids, it's younger and younger. We're talking about. I'm getting questions about opening up a pediatric psych unit. Now, Nationwide is doing it. In my previous life, we had it. So you imagine this, you go on a psych unit and there's 4 and 5-year-olds there. But the stress and anxiety, this continuum is moving down to all of our children. And to think that 6 and 7-year-olds want to take their life and have a plan to do so and the know-how and the wherewithal to do it is frightening. It's frightening. But that's an absolute trend. Just ask your pediatrician how much they're being asked to manage anxiety now. And your primary care docs and your pediatricians, 70% of the patients walking through their doors now, it's behavioral health. It's not even medical. That's why they don't even want to do it, because they don't know what to do with it.
I'd love to hear from you either best case scenario or best practice. If somebody's recovering from fentanyl or opioids, what would be a best continuum of care 3 months and 1 year?
Fentanyl's tough. Addiction's tough. Experience tells me that most addicts have to be backed in the corner, exhaust all resources before they're going to be willing to say, I'm ready. That old saying, being sick and tired and being sick or tired is true. So to me, the question is, it requires further exploration. Are they ready? Because so often, and you know this, many of you in your own personal lives, especially with addiction, if you want it more than they want it for themselves, it never works. It leaves you resentful, it leaves you angry. They have to want it. So if they wanted it, then fentanyl takes, and heroin takes a long time to recovery from. That's why they use the medication-assisted treatment to decrease the cravings, because the brain never forgets that high. Now, what's trending now, though, this is how sick and twisted this thing is. We're seeing an uptick in methamphetamines again, and crack cocaine. I haven't seen crack in a while, but it's coming back. So this whole thing is like whack-a-mole, right? It's kind of going back to the war on drugs. Well, we're starting to figure it out for heroin. But then then the cartels start producing pure methamphetamine. So they start shipping that based on the need and desire of our population, right? So it's capitalism at its purest. And then now, the crack cocaine is coming back, and And some folks are using the medication-assisted treatment. There's one called Vivitrol. It's a shot, lasts 30 days. Patients will be taking that, but now they're also using meth. So they don't have the opioid craving, but now they're smoking meth. Meth is really hard to come back from. Does a lot of damage to the brain. And sometimes the brain never heals. But there's so many variables to recovery. Are they living in a house where it's supportive? Is their partner using? Do they want it? Do they have access to resources? That's why you can see discharging a patient, everyone is different. It's so complicated to figure out, is this safe? Is it not safe? What are their chances for a recovery? Are they going to hurt themselves? Are they going to hurt others? If you figure it out, let me know, will you? I got one more question. Gentleman over here.
My question is a two-part question. Can you tell us a little bit about the company you work for? Is it private? Is it an affiliate of another company? Is it listed stock? And the second part, based on your talk, are you a nonprofit by design or by result?
We're all nonprofits now, whether you have a for-profit intention or not, and we all have for-profit intentions. We're private equity backed, 4 hospital system, 1 in Houston, 1 in Cincinnati, 1 in Delaware, 1 here. SUN actually stands for Solving Unmet Needs. In many ways, we function like a community mental health center, 50% Medicaid. Not that Medicaid patients need love too, no question. But what's shifted in my industry, where hospitals were used to maybe 2%, 3% Medicaid, 97% commercial because it's a better payer. Everyone's in the Medicaid game. And now we're trying to figure out, do we have enough resources to do the regulatory piece, to provide the products, to do things like yoga. So the resources are thin, and that whole for-profit, nonprofit, that's really going away. It's really these community integrated services. So we're all in many ways functioning like nonprofits, and even though we have a for-profit status. So thank you for your time.
Thank you, Scott. You'll probably stick around a little bit afterwards if you have some more questions. Thank you all for coming today. We look forward to seeing you again next week when our speaker will be Greg Scheck, one of our own new members. So come and hear what he has to say next week. So look forward to seeing you. Thank you all for coming.